Welcome to the Skeptic's Guide to Emergency Medicine. Meet 'em, greet 'em, treat 'em, and street 'em. Today's date is July 9th, 2026, and I'm your skeptical host, Ken Milne. The title of today's podcast is Every Time You Go Away and Survive Alive for 90 Days, is it due to a restrictive fluid strategy or early vasopressors? And to help us answer that question, our guest skeptic is Dr. Aaron Skolnik. He's an assistant professor of emergency medicine at the Mayo Clinic Alix School of Medicine and vice chair of critical care medicine at the Mayo Clinic in Arizona. He is board certified in emergency medicine, medical toxicology, addiction medicine, internal medicine, critical care, and neurocritical care. I think a shorter list would be, what hasn't he done a fellowship in? Aaron is a full-time multidisciplinary intensivist and enjoys serving as the medical student clerkship director for critical care. Welcome back to the SGEM, Aaron.
Thank you so much, Ken. It's great to be here in Alaska with you. Although not sunny Alaska, but it's beautiful outside. We're watching the tram come down from the mountain as we record this podcast.
Yeah, it's supposed to be the land of the midnight sun, but it's been a little overcast here. But you know what? I've been loving the weather because it's not too hot. It's a little cooler because we are doing a lot of hiking. We've gone out and looked at a glacier. We've hiked up to waterfalls. I mean, these courses that we do for the year in review for the Center for Continuing Medical Education, they have such amazing locations, obviously great faculty. But it's really, it comes down to the attendees. And when you get a course and there's some great attendees there and it's interactive, boy, the whole experience becomes just amazing.
Yeah, we've got people here from multiple disciplines and multiple specialties of medicine who, really push the limits of our knowledge and our interpretation of literature and ask all the right questions and bring up new ideas and new therapies that sometimes we haven't heard of. And it's just a great engagement. And then, in the off time, I've got my kids here to run me ragged and require me to have the world's darkest blackout drapes every night.
And I'm going to hit the pool with them later and play sharks and minnows and Marco Polo. And it's going to be so much fun after we finished recording. But, this course, this year in review, we cover, it's 260 plus papers over 4 half days. And it really is incredible to look back at, 2025, put this together, put this content together, and then sit with this audience and have a conversation, because we're not here to tell them how to practice medicine. We're here to talk about our interpretation of the literature. They may interpret it differently, and certainly how they apply it at their own institution will vary depending on who they are and where they practice.
That's right. And I think, for those of us that are more like me and less like Ken, by that I mean not a world-class expert in evidence-based medicine or critical appraisal, but, I think that's one of the really amazing things about the format is that you're not just learning, what does the literature say? Because sometimes it says things that aren't true.
That's it, yeah.
And if maybe Ioannidis would tell us it says things mostly that aren't true. And I think, I've learned a lot from serving as faculty here about how do you approach literature and how do we organize into some kind of hierarchy of evidence all of these papers with sometimes conflicting outcomes, right? And what does this mean to me? And is this going to change my practice? And if so, how do I implement that in my rural Ontario ED, or how do I implement it in my quaternary care center, in an urban environment?
Yeah, you're not even tertiary, you're quaternary, you're the Mayo, and you're working at the Mayo in the intensive care unit. So to see how the same literature can be interpreted and implemented downstream may be different than, when you're in a single critical access hospital going, oh, do I run fluids? Do I run vasopressors? How's that going to impact the patient care? I mean, we had a panel session this afternoon, and I actually explicitly said on the panel session, it's so great to have you here, Aaron, because I learn so much from you, because it's not the world I work in. And, we've had conversations about phenobarb for alcohol withdrawal that I've learned a lot from you. So there's so much to always learn, so much more to always learn. So it really teaches me to be humble and have humility when I'm surrounded by such smart people.
Oh, thanks, Ken. I appreciate that. And of course, the same thing goes. We don't just get together so the kids can spend time with Funkle Ken.
That's the only reason I come, is just so I can hang out with your kids.
Something about evidence-based practice. But The other thing that's great about papers like the one we're about to review is that, in this case, the tested interventions are things that are probably pretty applicable broadly, right? Fluids and vasopressors and antimicrobials and peripheral IVs. These are things we can do in our rural ED, and these are things we can do in our quaternary ICU, to borrow the Canadian pronunciation there. And so, whether you're in the emerge or whether you're in the intensive care unit, this paper is something for everybody.
Well, let's jump into it and start it off with a case if you can, Aaron.
Okay, so a 69-year-old man presents by EMS to the emergency department with fever, productive cough, confusion, and weakness. I wonder what it could be. He has hypertension, type 2 diabetes, and mild chronic kidney disease. His initial vitals are a temperature of 38.8 Celsius, a heart rate of 118 beats per minute. His blood pressure is 82/48, respiratory rate of 28 beats per minute, and saturating 90% on room air with a GCS of 14. He looks mottled. He's got delayed capillary refill, crackles at the right lung base, and dry mucous membranes. A chest x-ray suggests a right lower lobe pneumonia. Labs show a white blood cell count of 17,000, creatinine of 1.8, lactate of 3.4 millimoles per liter. Blood cultures are drawn, broad spectrum antibiotics are started, and he receives a liter of balanced crystalloid. 30 minutes later, his mean arterial pressure is about 60. And the resident asks you, should we give more fluid to get to 30 mLs per kilo, or should we start some norepinephrine now?
And so this is a great way to start this episode because it's not a diagnostic dilemma. We know this person is sick and it's an infection and they are hypotensive. So we're not talking about, oh, what could it be? Like you mentioned, we're saying, what should we do about it? How can we help this person? And they're septic, and sepsis remains one of the high stakes and humbling diagnoses in the emergency department. It's not as simple as infection plus abnormal vitals. Sepsis 3 reframes sepsis as a life-threatening organ dysfunction caused by a deregulation of a host response to that infection, moving away from that older SIRS-based definition and retiring the term severe sepsis. Septic shock is now generally understood as sepsis with persistent hypotension requiring vasopressors to maintain that mean arterial pressure, or the MAP, of at least 65 with a lactate greater than 2 despite adequate volume resuscitation.
So for emergency physicians or anyone working in the emergency department, the challenge is that sepsis is still a clinical diagnosis that doesn't have a single gold standard test. And systemic inflammatory response syndrome, or SIRS, has the characteristics of a highly sensitive but not very specific test. And the Q-SOFA score, or the quick SOFA score, may predict mortality, but it's not sensitive enough to exclude sepsis in the ED. A lactate is useful for risk stratification, but it's also not a magic wand or a panacea. And procalcitonin is not accurate enough to rule in or rule out bacterial infection. And the SGEM has repeatedly emphasized that sepsis screening tools, biomarkers, and bundles should be used with healthy skepticism and not just blind obedience.
Yeah, the practice of medicine is hard and nuanced, and it can't be often distilled down into some rule or tool or one, oh, look at the lactate is this, therefore that. Now, getting into the treatment in the ED, it usually starts with the basics. First thing, hey, could this person be septic? So recognizing that they could be septic, obtaining cultures, and when appropriately without delaying the care, give appropriate antimicrobials, seek out source control, and support perfusion. The resuscitation controversy has evolved over the last 2 decades. When I was talking about this 10, 20 years ago, it was the early goal-directed therapy, and that gave way now to usual care trials that challenge the protocolization of things like central venous pressure and various targets. Fixed fluid mandates have also been questioned, and many clinicians now worry about both under-resuscitating and fluid overloading the patients. As the SGEM has argued in the past, rigid bundles based on low certainty of evidence, does it really improve patient-oriented outcomes, or POOs?
Yeah, so that leaves a very practical, and as you've said, Ken, decades-old bedside question, right? Which is, after the first liter or two, should we just keep pouring in the volume, or should we start some vasopressors earlier? Fluids can certainly improve preload and perfusion in patients who are fluid responsive, but excessive fluid administration can worsen pulmonary edema, can worsen tissue edema, can exacerbate organ dysfunction. And vasopressors can restore vascular tone and perfusion pressure, but they also raise concerns about their adverse effects like ischemia, the need for monitoring, what's the right kind of IV access to administer them safely through, which I think this study contributes to some of that knowledge, and resource use, right? If you're on pressors, last time I checked, you have to be in the ICU. And these are exactly the kind of emergency medicine questions that deserve a patient-oriented answer. And as we say on the Skeptic's Guide to Emergency Medicine, they're called guidelines. They're not guidelines.
Exactly. So, Aaron, what's the clinical question we're going to try to answer on today's episode?
In adult ED patients with early septic shock, does a strategy of restricted fluids and early vasopressors, compared with more liberal fluids and later vasopressors, increase the days alive and out of hospital at 90 days?
And the reference for this?
Yeah, this is the ARISE Fluids trial from the ARISE Fluid Investigators, Vasopressors or Fluids in Early Septic Shock, New England Journal of Medicine, June 2026.
Yeah, so this is just last month. Let's run through the PCOT. What was the population?
The population was adults presenting to the ED with a clinically suspected infection, systolic blood pressure less than 90 millimeters of mercury, or MAP, mean arterial pressure less than 65, despite at least 1 liter of IV fluid boluses, lactate greater than 2 millimoles per liter, and IV antimicrobials started.
And so that was the inclusion criteria. That's how you got into this. They had some exclusion criteria. One of the key exclusions was you'd already gotten 2 liters of IV fluid before enrollment, or it was greater than 6 hours since you presented to the emergency department. If there were some care limitations to the institution, you required immediate surgery. And again, this is an important subjective one, if the clinician determined it was unsuitable. So you had to have some clinical equipoise to get into this. What was the intervention itself?
Yeah, so there was a restricted fluid strategy which employed early vasopressors. IV resuscitation fluids were stopped after randomization. Vasopressors were started. You were allowed to give 250 ml boluses for specified signs of persistent hypoperfusion.
And what did they compare it to?
They compared that to patients who received a greater fluid volume with later vasopressors. So those patients received up to 1 liter initially and then 500 ml boluses for persistent hypotension or hypoperfusion. 30 mLs per kilo within 3 hours was recommended unless it was contraindicated.
Okay, and so let's focus in on their outcomes. What was their primary outcome of concern?
Primary outcome of concern was days alive and out of hospital from randomization up to day 90.
And then they had a number of secondary outcomes, and I'll list those in the show notes. What was the type of study?
This was an investigator-initiated, multi-center, open-label, parallel group randomized controlled trial.
And so the author's conclusions were, quote, among adult patients who presented to the emergency department with septic shock, an approach that involved restricted fluid volume and early vasopressors did not result in greater number of days alive and out of the hospital at day 90 than an approach involving greater fluid volume and later administration of vasopressors. So that's what they felt. Let's go through a quality checklist for RCTs. Did the study population include or focus on those who present to the emergency department?
Yes. Adult patients were enrolled after presenting to the ED with early septic shock.
And do you think the patients were adequately randomized?
Yes, they were. Randomization was 1-to-1 using a computer-generated variable block randomization, and that was stratified by site.
And was the randomization process itself concealed?
Yes. Allocation occurred through a secure, password-protected web-based system that was available 24/7.
So it wasn't a bunch of opaque envelopes.
That's right.
All right. The patients, were they analyzed to the groups to which they were randomized?
Yes, mostly. Patients were analyzed according to assigned group. 37 randomized patients were excluded because consent or permission for data use was not obtained. And this is best described as a modified intention to treat analysis.
Okay, and were the patients recruited consecutively with no selection bias?
No, they were screened systematically, but this was not strictly consecutive enrollment. Of 2,080 patients meeting the inclusion criteria, 1,000 were randomized. Many were excluded because one or both strategies were considered unsuitable or because the protocol could not be delivered.
Okay, and were both groups similar at baseline with respect to prognostic factors?
Yes. Baseline characteristics appeared well balanced, including age, illness severity, lactate, blood pressure, pre-randomization fluids, infection source, and time to antibiotics.
And were the participants, the clinicians, and the outcome assessors, were they all masked to group allocation?
No, patients and treating clinicians were not blinded. However, the trial statisticians and management committee were blinded until the blinded analysis was completed and accepted.
Okay, and were all groups treated equally except for that specific intervention?
Unsure. This was a pragmatic trial. So antibiotics, source control, map targets, vasopressor choice, fluid type, corticosteroids, and other co-interventions were at the clinician discretion.
Was follow-up complete?
Yes. Follow-up for the primary outcome was excellent, with only 3 patients in the fluids group that were lost to follow-up.
And do you think that all patient-important outcomes were considered?
Yes, the trial considered days alive and out of hospital, mortality, days alive and at home, organ support-free days, adverse events, longer-term disability, quality of life, and cost effectiveness. Some longer-term outcomes are planned for separate reporting.
And do you think that the treatment effect was large enough and precise enough to be clinically significant?
No, the primary outcome showed no statistical difference. Median days alive and out of hospital at day 90 were 76 in both groups, with a median difference of 0.0 days and 95% confidence interval ranging from minus 2.7 to 2.7.
So that's pretty symmetrical, right? They got the identical point estimate, a 0 number of days difference, and that 95% confidence interval perfectly spanned the point of no difference. Where'd the money come from?
Always a great question, Ken. And in this case, the trial was funded by the Australian National Health and Medical Research Future Fund and the New Zealand Health Research Council. The appendix states the funders had no role in design, conduct, analysis, interpretation, or reporting.
So, the money didn't play a role in, figuring out how to do this trial and stuff. But what about the authors? Did they have any conflicts of interest?
Yes, at least 2 authors had potentially relevant professional or industry disclosures. However, there were no obvious trial-specific commercial conflicts that were apparent.
All right, so that's the quality checklist. Let's get to the key result. What was it?
In adult ED patients with early septic shock, restricted fluids with early vasopressors did not improve days alive and out of hospital at 90 days compared with a more liberal fluid strategy and later vasopressors.
And for that primary outcome, we already talked that it was the median days alive at 90 days, and it was 76 in both groups, and obviously it wasn't statistically significant. A P of 1.
Yeah.
That's how not different it was. How about the secondary outcomes?
Well, mortality appeared similar. 28-day mortality, 12.9% versus 10%, and 90-day mortality, 16.4% and versus 14.4%. Days alive and at home at day 90 were also similar. Invasive ventilation and renal replacement therapy were similar. Pulmonary edema was lower in the vasopressor group, 0.6% versus 5%, though the authors noted this could partially reflect the reporting bias in an unblinded trial.
All right. Well, Aaron, I love talking nerdy. I mean, we've been, this is day 3 of the course. We've been talking nerdy for 3 days. So I love talking nerdy. So we're going to talk about 5 points that add some limitations to this study. And we've already mentioned a little bit about the first one, and that is about the modified intention to treat analysis. They randomized 1,000 patients, but 37 patients were excluded because informed consent or permission for data use was not obtained, leaving 963 patients in the analyzed population. This was balanced between the 2 groups, and I want to be very clear, this number of patients that were excluded from analysis, it's really unlikely to overturn a result that had a point estimate that was identical and a p-value of 1. But from a purist standpoint, we can't say that it was an intention to treat analysis. It was a modified intention to treat analysis. But again, I don't think that this would have had any meaningful impact on their outcomes.
And Dr. Stephen McDonald, who was kind enough to offer, as an author of this trial, commentary on this, talks a little bit about performing a trial under a waiver of consent with a subsequent consent offered to the patient.
Yeah. We emailed him, and he was nice enough to get back to us with an email to help us understand this process better.
Yeah. Number 2, let's talk about selection bias and external validity. So this trial applies to a selected group of adult ED patients with early septic shock after at least 1 liter, but not more than 2 liters of IV fluid, lactate greater than 2, antibiotics started, and randomization within a narrow ED time window. So lots of real-world septic shock patients, by necessity of the design, were excluded, including those who had already gotten more than 2 liters of fluid, who showed up late, who required immediate surgery, who had treatment limitations, who were expected to have imminent death, who had low likelihood of 90-day survival, or were judged by the clinicians to be unsuitable for one or both treatment arms. And this makes the trial very relevant to early ED septic shock, but less applicable to patients who are already fluid overloaded or profoundly hypovolemic, who are perioperative, late presenting, transfer patients, palliative care patients, or outside of systems where peripheral vasopressors and ICU level monitoring are readily available.
The third nerdy point we wanted to talk about was the open label design. Patients and treating clinicians were not masked to group assignment. And this is understandable for a fluid versus vasopressor strategy trial, but it can influence clinician-mediated discussions such as additional fluid boluses, vasopressor initiation, corticosteroid use, ICU admission, ED and ICU discharge timing, and reporting of adverse events. This is especially important for the pulmonary edema, which was defined as related to the study intervention, quote, in the opinion of the treating clinician, end of quote, with clinical documentation including respiratory distress, chest x-ray findings, diuretics, CPAP, PEEP, or increased oxygen. The statistician and management committee, of course, were masked until the blinded analysis was complete, which helps, but does not remove bedside performance bias.
Number 4, substantial clinician discretion. So this was not a tightly controlled efficacy trial of a single therapy. The fluid type, vasopressor route, target mean arterial pressure, fluid responsiveness assessment, corticosteroids, source control, antimicrobial management, and other aspects of care were left to the treating clinicians. And that kind of pragmatic design makes the trial more generalizable to real ED and ICU practice, but it also makes it harder to isolate whether outcomes were driven by less fluid, earlier vasopressors, peripheral vasopressor administration, ICU availability, or other co-interventions. The pragmatic design improves applicability, but it weakens mechanistic clarity.
And the fifth and final thing we wanted to talk about, because I'm always talking about the poo. I love talking about the poo. It's the patient-oriented outcome. And days alive and out of the hospital at 90 days is a very patient-oriented outcome and was chosen with patient input because it captures both survival, but also morbidity, because if they're well enough to go home, they're functioning at some acceptable level. However, it can still be influenced by discharge practices, readmissions ICU capacity, rehabilitation access, and local health system factors. More importantly, the main publication did not report the planned longer quality of life and disability outcome. The protocol included death and disability at 6 and 12 months using a various scoring system and quality of life score and cost effectiveness, but these were planned for separate reporting. Mortality is objective, but survival with severe disability or poor quality of life may be worse than death for some patients. So the absence of these outcomes in the main report still limits the bedside interpretation, but we look forward to seeing that data being published further down the road to inform our care. And I've got a super special, exciting thing for SGEM listeners. We did reach out to Stephen McDonald. Dr. McDonald was kind enough to email us back. And then I extended him an invitation. I said, wait a minute, you're one of the senior investigators for this Arise fluid trial. And congratulations to you and your team for asking a good question, using good methods, and successfully publishing your trial. What do you think of our critical appraisal? So we shared it with him, and he recorded his thoughts for us. So I'm going to play that now.
Thank you for the review of the article and for the opportunity to add to the discussion. There are a few additional points to consider. Because of the time-critical nature of septic shock, patients were randomized under a waiver of consent, with subsequent consent to continue in the trial sought from the participant or the next of kin. 37 participants, balanced evenly between the groups, did not consent, so their data was not included. The sample size calculation included an inflation factor to allow for this. All participants who provided consent to continue were included in the intention to treat analysis. While therapies other than fluids or vasopressors were at the discretion of the treating clinician, we collected data on the use of steroids, antimicrobials, and source control procedures. These are reported in the supplementary appendix, available online with the published article. There was no difference in the primary outcome of days alive and out of hospital, overall, or in any pre-specified subgroup. The point estimates for mortality were higher in the vasopressor group, although the 95% confidence intervals all cross 1, meaning that potential benefit also cannot be excluded. The trial was not powered for mortality, so conclusions cannot be drawn, but nevertheless caution is required. The vasopressor groups ceased vasopressors more quickly, but this was offset by a higher proportion being commenced on vasopressors and also admitted to the ICU. Pulmonary edema was higher in the fluids group, although there is a risk of ascertainment bias in an unblinded trial. This was mitigated by having defined diagnostic criteria and requiring that all patients be assessed specifically for this outcome by the site investigator. The point estimate for the median time to cease ventilation was also shorter in the vasopressor group, although the threshold for statistical significance wasn't reached. My take on the results: firstly, a fixed volume of resuscitation fluid, such as 30 ml per kilogram, is not supported. Some patients need fluid and others don't. Clinicians excluded patients from the trial for whom they did not have equipoise. Patients in the trial received a median of 18 ml per kilogram pre-randomization and 7 ml per kilogram in the vasopressor group and 20 ml per kilogram in the fluids group over the first 6 hours of the intervention. So it appears that initial fluid resuscitation volumes within this range are safe. Peripheral vasopressors are safe, certainly for the first 6 hours, which was the median duration in both groups. Hemodynamic resuscitation in septic shock should be individualized. IV crystalloid fluid boluses should be titrated to assessments of volustatus and to bedside indicators of perfusion. Vasopressors should be commenced if deemed necessary and may occur concurrently with fluid resuscitation. Overall, the judgment of an experienced clinician at the bedside is probably better than an algorithmic approach. 12-month follow-ups are continuing and will collect mortality, disability, and health-related quality of life. The planned health economic analysis will be important given the potential trade-offs between increased requirement for critical care beds versus potentially shorter durations of organ support. The implications of the ARISE Fluids trial may be operational as much as clinical.
Thank you to our friend Casey Parker in Australia for getting us connected with Stephen McDonald and helping us learn more about this trial. Aaron, can you comment on the author's conclusions and compare them to the SGEM's conclusions?
We generally agree with the author's appropriately conservative conclusion.
And can you give an SGEM bottom line?
I think the bottom line is that in adult ED patients with early septic shock, don't drown them in crystalloids and don't squeeze them reflexively with vasopressors. Assess, individualize, treat the patient, not the protocol.
Oh, I love that. Treat the patient, not the protocol. What a brilliant thought. All right. And how about the resolving the case you presented at the beginning of the podcast?
Your patient has pneumonia-associated septic shock with persistent hypotension after a liter of crystalloid and a lactate of 3.4 millimoles per liter. You continue antibiotics, reassess perfusion, check a lung ultrasound and caval ultrasound, or perform a passive leg raise if feasible, and you give small additional boluses only if he appears fluid responsive. Because he remains hypotensive, you start norepinephrine through a well-functioning peripheral IV while arranging ICU admission and ongoing monitoring, and you do not reflexively chase 30 mLs per kilo if the patient is not fluid responsive or starts showing signs of pulmonary edema.
And can you tell us how you would clinically apply this really big trial that was just published last month?
Yeah, I think Actually, Dr. McDonald may have said it best, right? This trial should not be interpreted as early pressors for everyone, nor should it be interpreted as 30 mLs per kilo for everyone. It supports a nuanced approach. How much fluid should you give in septic shock? Just enough, not too much, right? That's what I always say. So give initial fluid, reassess frequently, avoid automatic large volume resuscitations, start vasopressors when hypotension persists, rather than waiting until the patient's received an arbitrary volume. The priority is early recognition, early antimicrobials, early source control, hemodynamic support, and bedside reassessments.
And so how would you translate this study to the patient's bedside?
I would tell the patient you have a serious infection that's making your blood pressure dangerously low and putting stress on your organs. We're treating the infection with antibiotics and we're supporting your circulation. Some fluid is helpful, but too much can collect in the lungs and cause some harm. We might also use a blood pressure medicine through the IV to support blood flow to your brain, your heart, and your kidneys while those antibiotics start working. We're going to be watching you very closely and adjusting treatment based on how your body responds.
All right, so what's the Keener contest question this week?
What sepsis term was retired by the Sepsis 3 definitions?
All right, and if you know the answer, then just shoot me off an email to the sgem@gmail.com. Put Keener in the subject line, and the first correct answer will get a shout out on the next episode. We have so many prior episodes on sepsis on the SGEM, and I'll list those in the show notes. But hey, thanks, Aaron, for taking time. It was nice to have a little bit of a break just to do something nerdy like this before we head to the pool.
No, thanks again for having me, Ken. I learn something new every time, and I appreciate it.
All right, and before you go, can you read the SGEM tagline?
Remember to be skeptical of anything you learn, even if you heard it on the Skeptic's Guide to Emergency Medicine.
Talk to everyone next week.